Urinary bladder cancer imaging considerations. Computed tomography. CT urography has a sensitivity and specificity of over 90% for the diagnosis of bladder cancer in patients with hematuria. In patients who are at low risk for cancer, such as those less than 40 years of age or female non-smokers, CT urography may be sufficient for detecting the presence of bladder cancer. Despite these encouraging results, CT urography cannot be used as a replacement for diagnostic cystoscopy in most patients with suspected bladder cancer. CT does not typically allow the confident diagnosis of flat lesions and lesions at the bladder base adjacent to the prostate gland, particularly in patients with benign prostatic hypertrophy. A major difficulty is differentiating tumor recurrence from inflammatory wall thickening that occurs following endovesical chemotherapy and from scar tissue after TURBT. The general technique for CT urography has been previously published. The homogeneous opacification of urine has been claimed to improve bladder cancer detection, particularly on the non-dependent surface of the bladder. Specialist techniques have been suggested, such as having patients void prior to CT and then administering intravenous diuretics to increase bladder filling. It is possible to visualize bladder wall enhancement and thickness on nephrographic phase CT scans. Virtual cystoscopy has been performed with the installation of 300 to 500 milliliters of air or carbon dioxide into the bladder lumen via catheter. Although some small series have shown CT cystoscopy to have a sensitivity of over 90%, it is probable that any additional diagnostic sensitivity is outweighed by the invasiveness of the procedure, the fact that cystoscopy is required for the detection of small flat lesions, and the reduced sensitivity of virtual cystoscopy for dependent lesions, where there may be a pool of urine obscuring the mucosa. MR imaging. The study of the bladder requires high spatial resolution, which can be achieved with the use of a phased array external surface coil, such as cardiac coil, thin sections 3 mm, and a large matrix. Use of a rectangular field of view helps reduce imaging time, but care should be taken to avoid extensive aliasing, which is usually reduced by applying pre-saturation pulses in the phase encoding direction within the FOV. Preliminary localizer sequences are used to evaluate for appropriate coil placement and bladder distension. A 28 to 32 cm axial FOV is usually sufficient to evaluate the bladder and surrounding soft tissue structures. Optimizing echo time, usually 60 to 80 milliseconds, is crucial for achieving a high contrast to noise ratio, which is important in assessing the depth of bladder wall involvement. Significant artifacts in bladder imaging include lack of bladder distension, motion artifact, and Schenkel Schiff artifact. Lack of bladder distension may limit the detection of small tumors secondary to the trusor muscle thickening. On the other hand, over-distension of the bladder may result in patient motion and can decrease sensitivity for plaque-like lesions. Optimal bladder distension is achieved by instructing the patient to void approximately 2 hours prior to imaging. Artifact from bowel peristalsis, which can propagate from the abdomen into the pelvis, can be minimized by administering an intramuscular antiperistaltic agent and using anterior saturation bands. Motion correction on the imagers can reduce motion artifact in the area of interest by swapping phase and frequency. Chemical shift artifact refers to misregistration of spatial information caused by the difference in the resonance frequencies of water and fat. This artifact is evident only in the frequencies encoding readout direction and occurs at the water-fat interface. Typically, chemical shift manifests as high and low signal intensity bands along a water-fat interface perpendicular to the frequency encoding direction. The frequency differences between fat and water is 220 Hz at 1.5 Tesla and 448 Hz at 3 Tesla. At a fixed bandwidth, the pixel width of the band-like artifact widens as field strength increases, which can limit the visualization of disease, particularly around the bladder wall. This artifact appears as a thickened, dark line along the lateral bladder wall on one side and as a bright line on the contralateral side. To reduce this artifact, the bandwidth must be increased and the frequency encoding gradient changed to select the direction that least interferes with examination of the bladder wall adjacent to the tumor. MR imaging has been shown to allow more accurate staging of bladder carcinomas than CT because of its high soft tissue contrast resolution, which allows clear differentiation between bladder wall layers. MR imaging has also been shown to better depict intramural tumor invasion as well as extravesical extension and allows differentiation between muscle-invasive and non-muscle invasive disease. In addition, MR imaging has the advantage of involving the no-ionizing radiation. Currently, for local staging of bladder cancer, a multiparametric approach with conventional and functional sequences is useful. Axial spin echo T1 weighted images with a large field of view are used for evaluating the perivesical fat planes for extravesical tumor infiltration, pelvic lymphadenopathy, and bone metastasis. The urine in the bladder has low signal intensity on T1 weighted image, whereas the bladder wall has intermediate signal intensity and the adjacent fat has high signal intensity. On T2 weighted image, the urine has high signal intensity and the bladder wall has low signal intensity. Non-fat saturated fast spin echo T2 weighted images are obtained in the three standard orthogonal planes. The plane of acquisition perpendicular to the bladder mass allows optimal depiction of the relationship of the tumor to the underlying detrusor muscle. High resolution fast spin echo T2 weighted images of the bladder obtained in the three orthogonal planes with a small FOV and a large matrix are used to evaluate the detrusor muscle for tumor depth and invasion of the surrounding organs. The detrusor muscle appears as a hypointense line on T2 weighted images. In patients with superficial or papillary tumors, this layer of detrusor muscle is uninterrupted. In patients with muscle-invasive tumors, however, the low signal intensity of detrusor muscle is interrupted by the tumor. In patients with extravesical disease spread, a clear extravesical mass can be seen in stage T3B disease, and adjacent organ invasion can also be visualized in stage T4 disease. The multiplanar capability of MR imaging allows image acquisition in different planes to minimize partial volume averaging and optimize imaging when evaluating the depth of bladder wall invasion. Coronal images are used for delineating tumors located in the lateral bladder wall and dome, whereas sagittal images better depict lesions of the anterior and posterior wall and dome. Recent advances in MR imaging technology have made 3D imaging feasible. Relative to two-dimensional sequences, 3D sequences offer the advantage of shorter acquisition time, volumetric coverage without intersection gaps, and an improved signal-to-noise ratio. Techniques that are useful in rapid pelvic imaging include non-breath hold ultrafast spin echo T2 weighted images and steady-state free precision imaging sequences. Single-shot fast spin echo imaging is excellent for reducing patient motion artifacts with the same spatial resolution as conventional T2 weighted imaging, but with a slightly reduced signal-to-noise ratio. Dynamic contrast material enhanced MR imaging. The usefulness of dynamic contrast enhanced T1 weighted MR imaging is debatable, with some studies showing that it is a useful technique and others showing that it is of no additional value. Three-dimensional fat-suppressed fast-spoiled gradient echo T1 weighted images are obtained before and after contrast material enhancement. Three-dimensional acquisition allows multiplanar reformation. The normal bladder wall does not enhance avidly on the early gadolinium enhanced image, which becomes important in tumor imaging. In the early phase, 20 seconds after contrast material injection, bladder carcinoma tend to enhance more than the surrounding bladder wall. The bladder tumor, mucosa, and submucosa enhance early, but the muscle layer maintains its hypointensity and enhances late, 60 seconds. This early phase of contrast enhancement also helps distinguish the bladder tumor from the low signal intensity urine. On the late, more than 5-minute post-contrast T1 weighted image, urine has high signal intensity and the intraluminal portion of the bladder tumor is clearly depicted, although small bladder wall tumors are obscured. Diffusion-weighted MR imaging. Diffusion-weighted MR imaging is increasingly being used for cancer assessment throughout the body and has shown great promise in the detection and characterization of other genitourinary malignancies. The role of diffusion-weighted imaging in bladder cancer is evolving and has not yet been fully established. Diffusion-weighted imaging provides both qualitative and quantitative information that reflects changes at the cellular level concerning tumor cellularity and cell membrane integrity. For most bladder tumors, increased cellular density manifests as increased signal intensity on diffusion-weighted images, with reduced apparent diffusion coefficient at quantitative analysis. At some institutions, diffusion-weighted imaging is currently being used primarily for local staging. A single-shot spin echo echoplanar sequences performed with chemical shift selective fat suppression technique at B values of 0 and 1000 is used. Diffusion gradients are applied in the three orthogonal directions and the images are obtained in the axial and sagittal planes. The images are usually evaluated together with the T2 weighted images. Initial results in the evaluation of diffusion weighted images demonstrated reduced ADC in bladder cancer compared with the normal bladder wall. There is substantial inter-observer variation in ADC values obtained in region of interest in the relatively thin bladder wall. Therefore, changes in signal intensity seen on diffusion-weighted images are more useful than information from ADC measurements. Diffusion-weighted imaging in bladder cancer has been evaluated in terms of diagnosis, staging, prediction of histologic rate, and assessment of the efficacy of induction chemotherapy. It has shown improved differentiation between the tumor, muscle layer, and thickened submucosa, all of which have different signal intensities at diffusion-weighted images. Positron emission tomography. Positron emission tomography with 2-fluorodeoxide glucose is considered to be of lesser value in the local staging of bladder cancer due to urinary excretion of the radiotracer. A study of 55 patients with bladder cancer that was performed to evaluate the usefulness of PET-CT in preoperative diagnosis metastatic disease found a sensitivity, specificity, positive predictive value and negative predictive value of 60%, 88%, 75%, and 79% respectively. T-staging. In patients with known bladder cancer, the important staging question is whether there is muscle invasion, stage T2 or higher. The accuracy of contrast-enhanced CT in the local staging of bladder cancer is only 40 to 60%. MR imaging is considered superior to CT in demonstrating the extent of bladder wall invasion. Microscopic perivesical spread, stage T3A, cannot be identified at either CT or MR imaging. Macroscopic perivesical disease, stage T3B, can be confidently diagnosed as CT only in the presence of moderate tumor volume outside the bladder. Perivesical fat stranding may often be seen following the treatment of bladder cancer due to surrounding edema or inflammation and does not necessarily signify stage T3B disease. Contrast-enhanced MR imaging is only moderately useful in differentiating stage T1 or lower tumors from stage T2 or higher tumors, with an accuracy of 75% to 92%. The overall accuracy of contrast-enhanced MR imaging in determining tumor stage is 52 to 93%. Several recent studies have reported diffusion-weighted imaging to have a high sensitivity and specificity in the staging of bladder cancer. N-staging. The most common site of nodal metastasis is the obturator nodes. About 1 in 6 patients presents with lymph nodes above the aortic bifurcation, and 8% have presacral adenopathy. According to current TNM guidelines, common iliac nodes are considered to be in a secondary drainage region and indicate stage N3 disease. In lymph node staging, CT has an accuracy of 70 to 90% with false negative rates of 25 to 40%, whereas MR imaging has an accuracy of 64 to 92%. Conventional CT and MR imaging cannot help identify metastasis in lymph nodes less than 10 mm. Enlarged nodes may be reactive, so that specificity is also limited. Because extensive lymphadenectomy is increasingly being performed for muscle-invasive bladder cancer, there is less need for nodal staging of tumors in the pelvis. It is more important to identify nodes in the common iliac chain or in the retroperitoneum. According to recent published reports, diffusion-weighted imaging has shown promise in differentiating benign from malignant lymph nodes. Post-treatment surveillance. Because of the high rate of local recurrence, patients with non-muscle invasive bladder cancer must be followed up after treatment. Cystoscopy, urine cytology, and imaging of the Upper tract with retrograde ureteroscopy are usually performed annually. Given the high metastatic recurrence rates of muscle-invasive bladder cancer, the National Comprehensive Cancer Network guidelines for post-cystectomy surveillance include urine cytology, chest radiography, and abdominopelvic imaging every 3 to 6 months for the first 2 years. Following this period, imaging studies are indicated based on clinical status. Metastases usually occur in pelvic or retroperitoneal nodes. Less common sites of metastasis include the lungs, liver, adrenal glands, bones, and kidneys, and even the peritoneal space. Conclusion: early detection of bladder cancer is important since up to 47% of bladder cancer-related death may have been avoided. Conventional CT and MR imaging are only moderately accurate in the diagnosis and local staging of bladder cancer, cystoscopy and pathologic staging remaining the standards of reference. Whole body CT is the primary imaging technique for detecting metastases in affected patients, especially those with muscle-invasive disease. The role of newer MR imaging sequences in the diagnosis and local staging of bladder cancer continues to evolve. Advances in MR imaging technology have made multiparametric MR imaging feasible for the local staging of bladder cancer to optimize treatment.